Okay, good morning, everybody. I know some of us were up late last night watching the game. It was pretty exciting, but here we are this morning. So thank you for joining us for Grand Rounds. I have the pleasure of introducing Dr. Clara Chan, who is one of our very well-known cornea specialists at the University of Toronto. So she practices in cornea, cataract, and refractive surgery. And she's the medical director of the Eye Bank for the Eye Bank of Canada, Ontario Division. She's a preceptor in the Cornea Fellowship at the University of Toronto and the Toronto Western Hospital, and she's published over 140 peer-reviewed papers. She's taught courses nationally and internationally at the COS and the AAO, where she's also received an Achievement Award in 2015. She is the section editor for the cornea portion of the CJO, the cornea editor emeritus for iWorld magazine, and she's part of the Power List as one of the most influential ophthalmologists in the world. And it's truly a pleasure to call her a friend and a colleague. And I look forward to her talk this morning.
Thanks, Amandeep. So we actually have 3 case presentations from our residents at the University of Toronto. We'll start with Heba. So she's going to present on this case with sudden vision loss after trauma, kind of appropriate after last night's game.
Okay, hi. Oh, there is an echo. Okay, one second. Hi, everybody. I'm Hiba. I'm a PGY2 at the University of Toronto, and I'm presenting this very, very interesting case. Can everyone hear me okay?
Yes, we can.
Okay, so this is a case of sudden vision loss post-trauma, and thank you, Dr. Chan, for giving me the opportunity to present this case. So this is a 46-year-old male. He's otherwise healthy, and he was struck by a hockey stick for one day. Oh, wait. So some of my slides are for some reason not working, or they're out of order. Oh no, they're not out of order. Sorry. Yeah, so this is a case, his past ocular history, he had LASIK in 2004, a bit of dry eye and not a lot of myopia. It's always important for any trauma case to know if they're a high myope or not. And the emergency doctor, he calls me about 1 a.m. and he says it looks like a large corneal abrasion. I ask about the vision. He said it's count finger. So we're going to pull up our poll question here. So we're going to ask the audience, when would you see the patient for consult? Would you run to the hospital at 1 in the morning, or would you tell them to come tomorrow morning?
You know, we just got through CARM season, and they would all come in right away and see the patient for everything.
Who's the 1 out of 7?
All right, so I went in to see the patient right away, and so this was the history that I got. On one second. So this was the history that I got. His when he was struck by the hockey stick, his vision went black for about 10 minutes. But then after his vision cleared up, he noticed persistent blurry vision afterwards. And there's no eye redness or pain. On exam, the unaffected eye was 20/20. The affected eye was 2200. It pinholed to 20/40. Now, this is a cornea grand rounds. So typically for trauma, any pain is associated with anterior segment, and typically painless vision loss post-trauma is posterior segment. But this is a cornea grand rounds, and the patient has no pain. So I want to ask, or like have you guys think about what could possibly be going on here in this patient. Any thoughts from the audience?
Maybe we'll open up to one of the senior residents, maybe a PGY 3 or 4.
I know it's cornea grand rounds, but for painless vision loss, I always think post-trauma, like a vitreous hemorrhage. Given that it's a more anterior segment presentation, I would also think of something like a hyphema, perhaps.
Yeah, that's true. Hyphema and like a lot of corneal edema, maybe. But this patient had a LASIK flap dislocation because he had history of LASIK in 2004. And we can assume just by when he got the LASIK that it's likely not femto, it's likely a microkeratome, and those are less stable. So as you can see here, there's a conj injection and that the LASIK flap is completely dislocated. You can assume that there's a superior hinge up here, and then you can see that the patient was not dilated. This is actually traumatic mydriasis. Okay, so let's talk about the management of the case. Any thoughts on how you would manage this case overnight as a resident?
Actually, I was curious, how about when you saw the patient, was there an epithelial defect anywhere?
There was no epi defect, no. I think the emerge doc, what they saw was the actual dislocation, and they thought it was a corneal abrasion. And you know, that's why I asked for vision, because it just sounded strange, and the emerge doc didn't sound sure about what he was seeing. He said he described it as a semi-lunar like epi defect, so maybe he thought that the maybe he thought that the area of the attack, like the stroma, was an epi defect or something.
So that
But
part should have been, so the stroma part of the flap should have been staining with
yes.
polyphony.
Yeah, so maybe he thought that was an epi defect because, oh, yeah. So he described it as a semi-lunar epi defect. It just didn't make sense to me, so I asked about the vision, and when he said it was count finger, I said, oh, yeah, I definitely want to see the patient.
It's interesting he had no pain if there's an epithelial defect there, that's large.
Yeah, he didn't have any pain at all. He
So
was
why do you
completely
think-
calm.
Yeah, why do you think he had no pain?
I don't know. He doesn't have history of, like herpes or any sort of neurotrophic. Like he wasn't like high risk for any of those things. So I don't know. I'm not sure. I didn't test for corneal sensation, but yeah, he wasn't in any pain at all.
Yeah, so the interesting thing is a lot of contact lens wearers actually become neurotrophic just from
Oh, I see.
wear of the chronic contact lenses. So for anyone who's worn soft contact lenses, you're sticking a piece of plastic in your eye without blinking. It's a bit odd, right? So, and then versus some people, like you even like touch their cornea gently with a contact lens, it's like impossible to get a contact in them because their corneal sensation is so hypersensitive. So definitely contact lenses, especially soft contact lenses and hard contact lenses, actually, probably only sclerals, which do not come in contact with the cornea. But the fact of wearing something literally on the cornea every day can actually render a cornea neurotrophic. So I suspect for him, like before he had his LASIK, he probably had a history of soft contact lens wear. And then that sort of made his cornea neurotrophic. And maybe that's why he doesn't feel much pain now with
Oh,
his
I see.
stroma exposed.
That's true. That's a good point. Yeah.
So Claire, do they remain neurotrophic years after the cessation of contact lens wear? Interesting.
Yeah.
Okay.
And the
So,
LASIK
You know,
itself.
Clara, one other thing, we published this a while ago with when you're doing LASIK, you are severing the nerves in that the anterior nerves to the cornea, and that gives rise to a dry eye as well. So we know corneal sensation is decreased after LASIK. You would think it would come back after 21 years when this patient had the surgery. But that could also be the fact, is severing the corneal nerves during the LASIK itself.
Yeah, good point too. Okay, thanks. Have I continue?
yeah. So now we go on to management. How do we fix this thing? So any thoughts from the audience of how you'd go about this case at 1 a.m. as a PGY2?
Maybe we'll ask one of the 2s or 3s. What would you do if you saw this?
I don't know how to call on people.
Well, we may have to start since we're not getting mentioned in the answers, but I prefer not to. There's someone in the room help us out here. A 2 or anyone.
I could just tell you how I did it.
Sure.
So I called Dr. Chan, and we just learned about how to manage LASIK flap dislocation and how to make it look good. So basically what Dr. Chan recommended And what I did was to soak a Wexel in BSS and to fatten it up and then thin it out and sort of wring it out so that it's thin and wet. And then you carefully reposition the LASIK flap. You want to do careful movements so that you're not moving it around too much. And once it's well positioned, you put a BCL on, you start him on some steroids, some antibiotics, and you see him and see how it heals up. And then we learned about microstriae and macrostriae and how to get rid of those. Where you basically put you can actually inject BSS or saline underneath the LASIK flap to smoothen it out. So unfortunately, I couldn't find a nasal cannula overnight. So we did exactly that. We did the repositioning with a Wexel, put a BCL on, put him on Tobradex. I gave him Tobradex in the clinic, and we put him on Predfort QID and Vigamox QID, and we saw him the next day. And this was immediately post repositioning. This was the striae I was talking about. You can see there's a lot of striae here, like macro striae, but at this point, I didn't want to touch it too much. I really wanted to go in with a cannula, but Dr. Chan said to just wait it out. Hopefully it'll go away. And so we saw him on 1-day follow-up, and Dr. Chan, of course, knew everything, predicted that the striae would go away. They were nearly gone. His vision recovered 2025, and the LASIK flap was in place. The BCL was good, and he was told to just continue the drops and follow up in 1 week. And he was seen in a 1-week follow-up. The vision was stable. The striae had completely resolved, and he saw his original LASIK surgeon in between my visit, between the 2 visits at our hospital. And they removed the BCL, they discontinued the Vigamox, and they actually increased the Predfort to Q2.
You know
Actually
why?
to Q1, and then they've tapered him down to Q2. I'm not sure why. Is it to get rid of striae? I'm not entirely sure.
No, I think the concern is anytime you disrupt a flap, there's a risk of even late onset DLK, or
Yeah.
like excessive inflammation. I mean, his was restored fairly quickly, like he came into emerge same day type of thing.
Yeah.
So you know, the risk is a bit lower. And usually classic DLK is like within the first few days after immediate LASIK surgery. So in this case, but you can get like late onset post-traumatic or post flap disruption type of a DLK picture. So the increase in steroids is just to try to prophylactically prevent that from happening. So I think because this is just within the 1 week, that's what they did, was to increase the steroids.
And and circling back to the full question, so is there value in seeing the patient immediately as opposed to, can this wait a day is my question. Can a LASIK flap dislocation wait a day or wait until the morning?
So the textbook answer should be, and on an exam, like a Royal College exam, you should say you would go in. At a CARMS interview, you should say you would go in right away. But I think in reality, if the patient's not in pain, they pinhold, or I guess the emerge doc may not pinhole. But sometimes these patients actually don't realize that they've even had a disrupted flap. So we've certainly seen patients come in like a week later or even a month later, not realizing something's that happened, and they've actually re-epithelialized over that precentic stromal exposure area. And you can just kind of clean off all the epithelium and then try to replace the flap. Definitely the sooner you replace and reposition, the better the outcome, I would say, because once it's disrupted and kind of slid out of place, to try to get the striae to resolve takes much, much longer. Sometimes it doesn't, it almost like stays. And the vision, I think, is less optimal. So definitely the sooner you deal with it, the better. But I think, yes, it probably could have waited till the next day. But given that you don't have a pinhole vision from the emerge doc, someone presenting with sudden vision loss to count fingers, you should see them.
Yes.
As you did.
Yeah. And so just for the 1-day follow-up, the striae were nearly gone. And I was really tempted to go in with the cannula to try to get rid of the striae. And we decided to just sort of hold off on that and to just wait and observe. Is there any value in sort of like once the flap is repositioned to not manipulate it too much afterwards? And especially once the BCL is on too.
But you
Yeah,
know, one of the things is you're going to get swelling of the flap, and you've got a swollen flap that's got to fit into the same bed, bed that you've made. So you are going to get striae. As the swelling and the inflammation settles, the striae typically uh, get better, as was the case in this patient. The other thing is you need to be really cognizant and watch for epithelial ingrowth under the flap after these traumatic dislocations of the flap. So that's an important thing to watch for. And you got to be very meticulous when you're putting the flap back to make sure that if any epithelium has come under the flap, that you get rid of it at the time of repositioning.
And also just during my exam, I had like made sure there were no foreign bodies. I flipped the lids just to make sure because if you're repositioning and if anything gets in underneath the flap, that could be dangerous too. So I made sure there were it looked like a clean eye before doing anything. This was 1 week follow-up. It's not a very clear picture, but you can see the striae are just completely gone and the LASIK flap is completely attached. Or it's completely retouched. So that's it. It's a happy ending. The patient eventually followed back to where he originally got his LASIK done. And so the take-home messages for me during this case is that the anterior segment pathology should definitely be on your differential for acute vision loss post-trauma. It's not always, something like a retinal detachment or what have you. The emerge doc did not give me the vision when he presented the case. So he just said, oh, it's an epi defect, it's a corneal abrasion, and sometimes they'll just offer like, oh, you can see this patient, especially when they're late, when it's late, emerge docs will just offer like you to see the patient the next day, because they don't want you to come in. But because he sounded a little bit unsure, I asked for the patient's vision. I usually almost always ask for the patient's vision if I'm gonna to help me decide how to triage. If I was thinking about adding it on to the next day. And so he didn't volunteer the vision, even though it was count finger, he didn't volunteer that information. So definitely always ask for the visual acuity from the emerge doc if you're thinking about pushing it to the next day. And knowing when the LASIK was done, I kind of touched on this already, because you can differentiate whether it was done by femto or microkeratome. And then the definitely when you're repositioning the flap, as Dr. Slomovic said, and as Dr. Chan advised overnight, is to just intentional and effective movements. Don't manipulate it too much. And as Dr. Rai always says, perfection is the enemy of good. So just as long as it's in fairly good position, don't move it around too much, and be very intentional with your movements. And minimal striae, they will resolve with time. That's it. Thanks so much.
Great, thank you. That was great timing.
Great case, Heba.
We'll move on to our next case. Heba, can you put it up, please?
As Hamad brings his slides up, I think this is going to be something all of us will see at some point through the emerge, whether you work with residents or in a community hospital. Something like 2.5 to 3% of the population has had LASIK. So there's a lot of people out there for potential flap dislocations. Hamad, we're just waiting for your slides. So it's good. I mean, Heba, thanks for sharing the management of that as well. I think it's just something to always keep on the differential. And, it's something that can be looked past when it's subtle, but certainly very important to manage timely. So,
Thank
Hamad,
you.
Heba, can you share your slides?
Yeah.
Great. Okay, go ahead.
Hi, good morning, everyone. My name is Hamad Al Mohanadi. I'm a PGY3. So today I'll be presenting a case of corneal perforation after cataract surgery. So this is a 76-year-old man post-op week 6 that is post-uneventful phaco PCIOL treated with topical antibiotic, steroid, and NSAID, presenting with 2 weeks of gradual painless vision loss. Post-op week 4, he saw his optometrist who noted corneal edema and continued his drop regimen for 2 additional weeks. In terms of review of systems, it was negative for trauma, eye pain, photophobia, rash, joint pain, GI symptoms, mouth ulcers, and dysuria. For the past ocular history, he had an uncomplicated phaco PCIL in the right eye. Past medical history, he has hypertension, dyslipidemia, coronary bypass, and BPH. And these are his listed medications. So this is the slit lamp. On presentation, the vision was hand motion. So I'm gonna ask for a PGY2 to describe the picture here.
In less than 5 words.
Anyone can
So-
go.
So that's a slit lamp anterior segment image of the left eye. There is a bit of conjunction. And the cornea, there is an area that is possibly a corneal melt because there is iris prolapse and the hypopyon.
Okay, for time, we'll just keep going.
Yeah, go ahead.
Oh, yeah, can everyone hear me?
You can progress.
Rod, go ahead.
This is a slit lamp photo, showing looks like, the most remarkable feature is that there's, a hyperpigmented sort of, it looks like uvea coming out of the cornea, so it's consistent with a corneal perforation. There's a bit of injected planch there as well. I can't tell if there's a hypopyon, but it looks like there might be a small hypopyon as well.
All right, good job. So yeah, this is a corneal perforation, and it's about like a 4 by 2.5 millimeter iris prolapse there nasally, and it was sidal positive. The AC was shallow with the fibrin, dense fibrin reaction, and a 1 millimeter hypopyon. So I'm just gonna ask maybe a PGY3 to give us maybe a differential diagnosis of a corneal melt.
Yeah, I can do it.
So, we just had a case of pseudomonas with corneal melts. And the patient was using Navinac as well, chronic Navinac use.
All right, anything else? Just a list of differential.
We can just put it up. You can just advance the slide.
I would add to the differential diagnosis inflammatory conditions such as rheumatoid arthritis, PUK, infections as well can cause corneal melting and perforation. Toxic medications such as topical anesthesia, topical non-steroidal anti-inflammatory drugs, dry eyes, severe dry eyes can cause corneal melting as well.
Right, perfect. So the differential diagnosis here is autoimmune and inflammatory, such as rheumatoid, granulomatous with polyangiitis, infectious, bacterial, viral, or fungal, iatrogenic, and medication-related, such as post-surgical complication, topical NSAID, neurotropic from diabetes or trigeminal nerve dysfunction or chemical exposure. So in terms of the next steps, we did a B scan that showed vitreous debris. The patient was followed closely by a retina because there was some concern for an endophthalmitis. Repeat B scan didn't show a frank vitritis, and the hypopyon was stable. So it was less likely to be an endophthalmitis, just judging from the clinical course. 2 AC paracentesis cultures were done. There was no bacterial growth. We held off on corneal culture given no clear infiltrate on presentation. For the treatment, we glued the perforation with histoacryl glue and bandage contact lens was placed. Initially, he started on fortified vancomycin, tobramycin Q1, given that this is a post-op week 6, so cataract with hypopyon. After we excluded infectious etiologies, antibiotics were switched to Vigamox QID. Oral doxycycline 100 milligram daily and Maxidex BID were added. And this is just a video showing
Can you go back?
showing the PKP. So here we're removing the glue and exposing the iris prolapse, and we are taking measurements of the graft. Peritomy was done, and we are scraping.
So we want to make sure there's no
And we are-
epithelium
I'm sorry.
there, right? Because you don't want epithelium to grow into the eye and cause a downgrowth issue. So just being mindful of just
Peritomy was done, and we are removing the cornea tissue from the iris just to prevent downgrowth. Oh, I'm sorry. I think my speakers were off here. Was there any questions? Sorry, Dr. Chan.
we thought you were just muting us and
Oh.
that's okay.
Oh, I'm sorry about that.
Can you just go back one slide? I just wanted to touch on like the management of why we would add oral doxycycline. So maybe someone, I mean, I'll just tell you guys. So basically there's anti-MMP properties in doxycycline. So any sort of melting process, it's not a bad idea just to add it to slow down that the necrosis impact. So that's why that was added. And I do wonder, like for the AC paracentesis for cultures, the anterior chamber was somewhat flattened from the perforation. So that was not probably an easy thing to do. So it's interesting that the AC tap was done prior to, I think, referral to us. B scan's a good idea. And then the last point is that we can pretty much glue anything. And so it's very easy to glue with a dab technique using the back blue end of a Lexel. You just dab it into your glue, which is just essentially the histoacrylcyl crazy glue. You can order a package. They're like $20 per pack. You can get a package of 10, and it can last for years and years in the office. So it is very handy to have in the community. You just need even just the back of like a Lexel or the back of a Q-tip or anything. Probably something plastic is easier. Then you just dab it into the glue, and then you just dab it onto the eye, making sure that that area of the eye is dry. And it pretty much instantly polymerizes, and you've got a covered, closed ocular system in less than 5 seconds. And so once we've glued the patient, then there's really less urgency and rush to do anything. So that's why there's the time delay of the 5 weeks prior to organizing for a cornea patch graft / graft to be done. Alan, do you have any comments?
No, I think that covers it pretty nicely. I do the gluing a little differently. I do a disc application because when the glue polymerizes, it's very the edges are very sharp and it can tear a contact lens. So having that plastic, I actually just use a drape, the part that you throw away, and I trephinate about a 3 mm punch, and I use that to close the wound along with the glue. But I mean, that was handled nicely. And I agree, I didn't see much aqueous that you could extract there. The other thing that's interesting is there was no pain. And I'll discuss that later because I think I don't want to give away the diagnosis, but there was a reason for that.
Okay, great. So you can just finish off that video then.
Thank you. So the one AC paracentesis was done following the gluing. When the AC chamber reformed, they were able to enter the AC and do the paracentesis. And for the video here, you can see them exposing the iris prolapse, removing the glue, and here they're just taking measurements of the corneal graft. Peritomy was done to expose the area because it's going to be an eccentric PKP. They're scraping the iris because they're removing the cornea tissue to prevent epithelial downgrowth. And here you can see multiple attempts are being made to push the iris into the anterior chamber. However, it's very adherent to the cornea.
So the decision here to do we were trying to decide, should we do a full PKP, like a rounded 8 millimeter thing, or just try to patch that small area? And one of the challenges was that if we were just patching that small area, we would be suturing right into the visual axis, and you would have sort of the graft edge directly in the visual axis, which would be suboptimal. And so doing the eccentric graft at least would allow for the pupil to be within like a new corneal area. So that's what it was decided upon, to trephinate for a full, rather than just doing like a you know, half of a graft to patch the area that was perforated. But it's very hard to actually get suction with the trephine when you have a perforated zone. The eye's really soft. This was done under general anesthetic, and you know, the trephine didn't actually cut through very easily, so we had to kind of score it with the 15 blade to just make sure that we get our exact outline of the area that we wanted to excise. So somewhat more of a manual, you know, trephination rather.
So here they're using corneal scissors to remove the corneal button. And like Dr. Chan said, the PKP, the aim of it was to prevent the graft host junction from being on top of the visual axis. So just to have better outcomes, visual outcomes here. So you can see the iris very adherent to the cornea, and they will excise, here they're excising the iris from the corneal tissue. And
we managed to peel off a lot of the iris. Like, we didn't actually have to cut away too much iris. Most of it actually peeled off the posterior stroma reasonably well. And here we're just kind of trimming bits of iris where I was worried that the stromal epithelial maybe stuck to it. So just to hopefully prevent any risk of epithelial downgrowth, which is one of our more common concerns after trauma or perforations. So I use slip knots to do the PKPs, and I don't actually mark the eye typically, because I like to use the tension lines of the sutures to ensure that we're applying equal tension across the graft. So you can see the striae form initially with the cardinal sutures, like a nice kind of square, and then each of the sutures, you can see as it indents into the cornea, I force the fellows to kind of use their judgment in terms of, you know, looking at where the indentation of the sutures are to ensure an even distribution of the tension to try to reduce the astigmatism. I mean, in this case, he'll still have a lot of astigmatism because of the graft being decentered, but at least, you know, it's good training rather than relying on radial marking lines to do the suturing. Because the radial marking lines may not actually finally line up to your graft. Given the neurotrophic nature, we put in a tarsorrhaphy. So this is actually like the quickest way you can put in a temporary tarsorrhaphy. It's a mattress suture. This is using Prolene 5.0 double-armed, just putting it through the gray line, in and out. You want the knot to be away from the cornea in case it scratches, but I mean, usually it's far enough away from the cornea if you're making it either lateral or nasal. In this case, the nasal side was sutured because that's where the perforation was. And so we just wanted it to be more protected to epithelialize faster. And so just that quick technique of putting in a mattress suture in through the gray line on the top and bottom and then tying it is probably your easiest way to do a tarsorrhaphy. And just continue with the final.
all right, so post-op week 1, status post PKP, left eye. Patient was on Vigamox, Maxidex, and Combigan, Diamox 250 BID. There was some high pressure at post-op day 0. The vision was hand motion, IOP was 15. And I just want to highlight that there was full reepithelialization of the cornea. The tissue culture showed no growth, and the surgical pathology showed squamous metaplasia, stromal fibrosis, and neovascularization. There was no bacterial infection there. So for the discussion, so this case, the most likely cause of the corneal perforation was NSAID use. Post-op corneal melt from topical NSAIDs may happen on week 1 to week 6. They tend to occur in the paracentral cornea and are sterile in nature. It's a rare complication. The true incidence remains unknown. Topical NSAID can reduce corneal sensation, which results in delayed wound healing and reepithelialization. And like what Dr. Chan mentioned with the torsorrhaphy, that was a really good idea because some case reports actually showed some issues with recurrent erosions in these presentations. So the torsorrhaphy really did wonders here. So most patients who develop corneal melt have underlying ophthalmic or systemic disease affecting the ocular surface, such as Sjogren, diabetes, rheumatoid arthritis, rosacea. So NSAIDs are more of a trigger rather than a direct cause of corneal melt. So careful pre-op screening for an optimization of advanced dry eyes is crucial before starting topical NSAID. Prescribe preservative-free lubrication eye drops when topical NSAIDs are used in patients, and close monitoring of patients at risk is a must when they undergo any ophthalmic procedure.
Great. So I think lots to unpack there. The biggest question is to use NSAIDs or not to use NSAIDs. I think most of us do use NSAIDs after a routine cataract surgery. In specific patients, if you can go back one slide, with the higher risk of severe dry eye disease, on my clinical exam when I see my cataract patients, if they have diffuse staining, even, you know, part of the test is actually like they've had drops in, their eyes numb from having their pressure checked. And even just in that sort of like short duration of time that they're in the office, or maybe a long duration if they've been waiting a while, it's almost like a good test to see how well their surface behaves. And if there's diffuse staining or even like 50% staining of the cornea, I will make a note to say no NSAID post-cataract. Looking for rosacea as well, I will give them doxycycline after their cataract surgery to make sure that there's no sort of upsurge of MMP immune modulators on the ocular surface, because I've had, knock on wood, just one melt that came in, and it was actually a rosacea patient. And I luckily just, typically I see my cataract patients like a week. We used to see them same day and then at a week. Now sometimes we'll see them even 1 to 2 weeks later, depending on scheduling. And this gentleman came in like 5 days later. This is pre-COVID. And so I had noticed like an oval central epithelial defect. Anything oval that doesn't have an infiltrate, you have to worry that it's a sterile type of melt, early process. And he had just horrible rosacea. And from that point, I, you know, put him on the doxycycline, heavy lubrication, stop the NSAID right away at day 5 instead of having the usual 2-week course. And he recovered with just 20/30, I think, vision finally. So luckily it was caught early. But definitely, Alan, you've, you know, had a few more years of experience. What are your thoughts on NSAIDs and cataract?
So I think first of all, excellent presentation, and I think you made the main points. You know, probably the most important takeaway point here is if you have a patient with dry eye or any other underlying autoimmune condition, NSAIDs is not a good idea. We've seen quite a few, not quite a few, maybe 10 or so corneal melts and some perforations with the use of NSAIDs in the dry eye setting post cataract surgery. So I think importantly for the general audience, don't put patients on NSAIDs if they have a dry eye or some sort of underlying autoimmune condition. It used to be thought that this was due to generic NSAIDs, but I've seen a couple on brand NSAIDs and who have melted. So I think that's the important point there. I think we've made a very good case with emergency docs not to put patients on steroids. And for them, I think NSAIDs have become the new steroids. So we are not the only people prescribing NSAIDs. It's also coming from some of the emergency docs. So I think importantly, what we take home from this case is that you know, be conscious of the possible side effects that the NSAIDs can have towards promoting corneal melts. And you know, the reason they often don't have pain because NSAIDs can reduce the sensation of pain from any corneal insult.
Yeah, and whilst Waleed's getting his slides up, also one last comment. A lot of practices, I think, are deferring even now their 1-week checkups to optometrists or other, physician extender types. And so not everyone may be able to recognize like an early, melt or an early eye at risk. So, I think deferring your 4 to 6 week checkup for a cataract may be reasonable, but having that 1 to 2 week checkup done by an ophthalmologist, I still think has value. Waleed, why don't you get going? Okay, this is our last case. So it's a bit it's probably the most dramatic one that involved a few specialties, and so we'll just have Waleed start.
Okay.
You have
Okay.
it on presbyopic center.
Is it good now?
Yeah, that's
Yeah, you're
good.
good.
Okay, great. So this is a case of a patient of a 35-year-old man who presented to the emergency department with upper respiratory tract endless symptoms, shortness of breath and fever, and he was found to have redness in the left eye for the last 10 days. He didn't have any previous eye issues, no contact lens wear, no trauma. The only thing in his past medical history was a positive pneumococcal pneumonia requiring ICU admission back in Australia in April 2024. He drinks alcohols occasionally, but no IV drug or substance abuse. CT chest was done in the emergency department, and it revealed the presence of an acute pulmonary embolism. He was started on rivaroxaban and was referred to the UHN thrombosis clinic. Ophthalmology was consulted, and they saw the patient. Patient had a vision of 20/50. It improved with correction to 20/80. The IOP was 44, and this is the slit lamp examination. Maybe one of the residents can describe the photo and tell us what the next step should be.
Maybe a PGY 3 or 4.
Okay, maybe we don't have time. I'll just fly through it. It shows the presence of diffuse corneal edema, bottom flat KPs, and this was diagnosed as hypertensive uveitis. A B-scan was done and it showed a normal retina. AC tap was done and sent for viral PCR, Predford, Vigamox, and Valtrex. 1 gram TID was started. The patient was seen a couple of days later. Unfortunately, the patient's condition worsened. His vision worsened to light perception. He had proptosis. He had limited extraocular motility. And as you can see on the examination here, he had total corneal abscess with large area of melting nasally at the nasal limbus. There was some vitreous prolapse, inferior conjunctival chemosis. So a decision was made to do a CT scan. Given the presence of proptosis and limited extraocular motility, corneal swabs were done and sent for culture and sensitivity. The patient was started on fortified vancomycin and tobramycin, and oral doxycycline, oral moxifloxacin were also started. CT scan showed the presence of periorbital and preseptal soft tissue swelling, along with the presence of irregular opacities within the globe involving the vitreous in the anterior chamber. And those signs were concerning for endophthalmitis and panophthalmitis. So the patient was admitted under general medicine. The blood cultures came back positive for Klebsiella pneumonia, and the patient was diagnosed with sepsis, causing septic pulmonary embolism. AC tap came back negative for viral PCR, including HSV, zoster, and CMV, and the patient was started on IV antibiotics. One microbiological test that was done is a string test, which was positive in this patient. Basically, this is a viscous string that is more than 5 millimeter in length, and this indicates a positive test. And this is a diagnostic of a hypervirulent form of Klebsiella. It's called hypermucoviscous Klebsiella pneumonia, and it can produce a capsule that can evade the immune system. So back to the case. Patient was seen the next day. The corneal melting continued to worsen. VA was light perception, and the corneal swabs came back positive for the same type of bacteria in the patient's blood, Klebsiella pneumonia.
So can we glue
Um,
this?
So that was a corneal scleral ulcer with endophthalmitis. The next day, the patient's condition continued to worsen, corneal melting, uveal prolapse, vitreous prolapse, and the underlying uvea and iris were seen, and the oculoplastic team was consulted for evisceration. Evisceration was successfully performed, and yeah, so if we can pull up a poll question here. What do you think, which systemic disease is associated with Klebsiella endophthalmitis? Is it chronic kidney disease, liver abscess, SLE, or TB?
As that's running, Walid, I can't recall. Did you say, was there any travel history?
He had a pneumococcal pneumonia back in Australia, requiring a ICU admission.
Okay. Nothing in Southeast Asia or anything like that. That's it.
No.
Australia has a lot of deadly things too.
Yes, I think I agree.
Okay, so we have a split between liver abscess and lupus erythematosus. Okay, great. So back to the case. The patient had some workup to identify if there's a source of his Klebsiella sepsis and endophthalmitis. So syphilis came back negative, HIV came back negative, COVID came back negative, liver ultrasound was normal, and urine culture was also negative. Post-op, after evisceration, the pain resolved, no evidence of purum discharge. The patient was given tobramycin ointment and was instructed to apply cool compresses. Repeat blood culture came back negative, no fever. The IV antibiotics were switched for ceftriaxone to ceftriaxone for 6 weeks, and the patient was discharged. So this is a case of a hypervirulent Klebsiella pneumonia causing sepsis and endophthalmitis, and also corneal ulcer and perforation. So this type of bacteria usually infects people from the community, causes community-acquired infections, it causes CNS infections, it causes endophthalmitis. It's different from the typical Klebsiella pneumonia, which is often associated with hospital-acquired infections. So this is a case, one of the first cases describing Klebsiella pneumonia in a patient who had liver abscess and septic endophthalmitis. They described 7 different cases of Klebsiella pneumonia associated with endophthalmitis. This is another study on 61 patients over a 20 period of patients with Klebsiella sepsis and endophthalmitis. The majority were male patients, the majority were Chinese. 77% had liver abscess. The outcomes were poor. 27% required evisceration. The adverse prognostic factors found in the study included rapid onset of symptoms, unilateral involvement, hypopyon, and panophthalmitis, which is similar to what happened in our patient, as opposed to posterior focal involvement.
I think that study was from Singapore though. So
Yep.
I think the predisposition of the demographics of their patient population being heavily more Asian descent patients is just based on the fact that this is a Singapore study. I think our patient that you presented was not of Asian descent.
Yeah. This is another study on 7 patients in Miami with Klebsiella endophthalmitis. And unfortunately, again, the outcomes were poor. The 3 patients who had the endogenous type of endophthalmitis required enucleation or evisceration. Another study on 19 patients with Klebsiella endophthalmitis. 18 of them had liver abscess. Prognosis was poor. 60% required evisceration. 20% had no light perception. 4 patients, 21% died. And the visual symptoms were underreported in patients with septic shock. So that's why the authors recommended universal screening in patients with Klebsiella sepsis, universal screening by ophthalmology. Last but not least, this is a case report of an 83-year-old Chinese woman who developed bilateral conjunctivitis, which progressed to corneal ulcer, corneal perforation in both eyes despite intensive antibiotic treatment. The patient was otherwise well, and investigations did not reveal an endogenous source of Klebsiella. So in conclusion, patients with Klebsiella pneumonia, bacteremia, and ocular symptoms should be evaluated urgently. Klebsiella pneumonia endophthalmitis is associated with poor prognosis and possible evisceration and enucleation. Klebsiella pneumonia keratitis, as seen in our case, may cause corneal perforation.
Why don't we go back a few slides? What was the answer then? There was just the one case report where the liver abscess was associated with the septic endophthalmitis caused by Klebsiella. So with your poll question of the 4 pathologies that you listed with the poll question, would you say that it's a liver issue that seems to be most associated? Or I don't think we have enough cases to be able to know whether there's a specific other end organ that's associated with ocular, outcomes being poor.
Yeah. So this study describes 7 cases of Klebsiella liver abscess and endophthalmitis, and this study also described 7 patients with Klebsiella endophthalmitis, and this study also described 18 patients who had liver abscess and Klebsiella endophthalmitis.
Oh, okay.
Only based on few case reports and a few case series. But yeah, I think it's definitely worth investigating for liver abscess in a patient with Klebsiella endophthalmitis.
Yeah, so this was an interesting case because usually when we get cornea ulcer referrals, we're looking for an epidefect where the bacteria could have entered from. It's very unusual to have an endophthalmitis eating outwards from inside the eye and through the cornea and out. Because even most of the endogenous endophthalmitis cases are contained to the vitreous with, especially in a phakic patient. So I think this case, the infection was not only from the endogenous like vitreous outwards, but also just like a scleritis combined with uveitis, and the infection luckily was just in one eye, but very well could have been in both, given the mechanism of being an internal to out infection, rather than your typical corneal injury infection from outside to in. So within 4 days, the guy lost his eye. It's very aggressive. And so even within 24 hours, probably less than, to just go from an intact cornea to nothing, was very dramatic. So wanted to end on that dramatic case. Any final comments from our panelists?
I mean, that's striking, just unbelievable. Young
And
guy.
a relatively healthy young guy.
Yeah. We usually have better outcomes. That's a remarkable case. Thank you for sharing that.
You know, Clara, the only time I've seen that kind of sequence of an infection coming from within towards the surface of the cornea, the epithelium, is very rare with suture removal. If you had a deep suture and you pulled let's say, an infected suture through through the cornea, you could get a deep infiltrate, which works its way forward. But you're right. I mean, this is really unusual, and there's no way. I mean, that cornea is mush. You can't do a transplant to that to try to save it. Even if the endophthalmitis wasn't present, you'd be like sewing through tissue paper, wet tissue paper, and it just wouldn't hold.
Yeah, it was essentially auto eviscerating as we're watching it. So anyways, I think we'll end there and have
What was the systemic outcome?
Oh,
Was there any?
Yeah, the infection resolved. Yeah, like the sepsis resolved, and he was well discharged home. Yeah.
Okay, good.
Yeah, well, thanks guys. Residents, good job with the presentations. Good cases.
Yes, thank you, everyone. Great cases, Clara. Great presentations. Waleed, Heba, and Hamad, thank you for that. And shout out to Hall Chu, who joined us from BC. It's 5 in the morning, and he's joined us. So good morning, Hall. Enjoy the rest of your day, everyone.
Okay, residents, I'll be there about 20 minutes to do teaching. See ya.
Okay.
Bye.
Thank you. Bye.